I'm Stacy. I'm with FSCJ for Evidence-Based Practice 2, and we're doing, it's a capstone paper which we do evidence-based practice based on a PICO question. Have you all learned about PICO questions? Okay. Mine basically was, does focused education for heart failure patients opposed to just a bedside nurse giving education or no education at all help with the readmission of heart failure? So just some facts. There's about 5.7 million people in the United States that have heart failure. Most of these, or about half of the people die within 5 years. It costs about $30 billion each year in the U.S. for the care, and it is the most common discharge diagnosis in patients over 65. 30 to 40% are readmitted within 6 months, which contributes significantly to the cost. And as you guys probably know or will learn, if you're admitted within 30 days of discharge, the hospital doesn't get reimbursed at all. Some risk factors of readmission are little to no discharge education, or say like a bedside nurse is like, oh, the nurse will do it tomorrow. I don't have time today. And then they come to discharge and they try to cram all the information at one day. Or different nurses are teaching different things because they don't have an educational standard. National guidelines are summaries of evidence-based practice, basically. They look at tons of studies done and they kind of find the best guideline that people should use when educating people or using it to treat people. There's a lack of interdisciplinary coordination. Y'all know what interdisciplinary is, like physical therapy, pharmacy, social work, home health nurse. Lack of teaching them how to take care of themselves, when they should take daily weights, or how to take their medication, when to take it. Lack of transitional care, if they need to go to rehab, if they don't have enough people at home to help them, or they're not strong enough to go home. And then progression of the disease. Unfortunately, it is a progressive disease. So for the sickest patients, they will get readmitted more often, and often hospice is a really good tool to use. If you guys learn anything about hospice, it doesn't necessarily mean you're going to die the next day. They are really great at managing chronic diseases, especially if they don't have insurance. They can get them access that they couldn't normally get. The national guidelines for CHF are really long, but I just took out the education part because that's what my paper's about. And they just say use comprehensive discharge planning and education. Make sure post-discharge services are in place. Like they need to have follow-up doctor appointments within so long of leaving the hospital. If they need to go to cardiac rehab. Make sure that there's multidisciplinary follow-ups, including pharmacy, physical therapy, social work, so that if they need anything at home, social work is good at making sure that they have all of that. And then follow-ups, whether a nurse goes to the house or if a trained heart failure nurse calls them, and they usually have like a scripted sheet where they kind of go through all the education that they've already had again and make sure that they understand what they should be doing. The nurses here that do it are the navigators. I don't know if you guys met them. We have 2, and they're specifically responsible for follow-up care. A clinical pathway is kind of like a set standard that we use for heart failure, and it's like day 1, this needs to be done, day 2, this needs to be done, day 3. So making sure that everybody kind of has a standardized care, that way they get everything they need. They need to have education on medications, what they are, what they do, the side effects. Like if they're a new heart failure and you give them Lasix, what are you going to tell them? It's going to make them
pee.
Yes. So if they take it twice a day, do you tell them to take it right before bedtime?
No.
Diet, salt restricted. If they're on a fluid restriction, if that's what the doctor recommends, you need to make sure that they understand a popsicle is liquid. Little things like that. Daily weights, how often they should do it, when they should do it, first thing in the morning, after they void, every morning. Warning signs, which is another slide that we'll see, but I guess we'll wait till we get that. And then exercise if the doctor says it's safe for them to do it. The in-home follow-ups, or if a nurse or a home care nurse can go to the house. The telephone follow-ups are for the hospital to follow up with, or the heart failure clinics. Referral to the heart failure clinics if available. I know here they only take a specific insurance unless they've been readmitted within 30 days, and they go no matter what. Pre-made doctor's appointments prior to discharge, they have to have a follow-up with cardiology within so many days. And they have to know when the appointment is and who to call if they need to change it. It's very important that they know that. And then home health or rehab if they need it. Here are some nursing interventions that you can do. Follow the clinical pathways when you're giving your education, because as a bedside nurse, it's just as important as the heart failure nurse. You're just giving smaller parts kind of throughout the day. If there is a heart failure nurse, make sure that she understands that they're there and that they need the education, especially if they're going to be discharged that day. Or if you know they're going to be going home over the weekend, make sure you get them during the week. The pre-made doctor's appointments, check that they're there, and then discuss with the physician if they're available to be referred for the heart failure clinic. These are the zones. We actually give this out, or a very similar one to this, to our patients here. Things that they need to do every day: weigh yourself, take your medications, and then the green zone is like you're all clear, you don't need to worry about anything. If you have a small weight gain, 1 to 2 pounds, that's okay. No swelling in the feet, no shortness of breath, no chest pains. Yellow, if you've had a weight gain of 3 pounds in one day or 5 pounds in a week, you need to call your doctor. Swelling the hands and feet, and then emergencies if you can't breathe, even if you're resting, chest pain, confusion. And that's just a good way for them to keep it on their fridge so that they can see that's part of their self-care. Finding time for education, this is the hardest part, I think, for all nurses. I like this little quote here. I found it on Crames, which we use for our education system too. Patients who have a clear understanding of their after-hospital care instructions, including how to take their medications and when to make follow-up appointments, are 30% less likely to be readmitted. So when you guys find time to teach, what do you think?
Discharge?
Teachers start.
When does it start?
Admission.
On admission.
Oh.
And when would you teach? Like when during the day? You're busy. You have a 12-hour shift, you have 6 patients. You have to teach somebody.
With the patient.
During care.
During care, yeah.
Or passing meds,
Mhm.
doing medication administration.
Always go over their medications with them, tell them what it's for, what they're gonna expect from it. Ask them if it's a new one, if they have any questions about it. Because a lot of times they're taking their regular daily meds and they know what it is. But if you know it's a new one, definitely go over it again. What other times do you think? When you're feeding a patient? I know you think ACPs do that, but nurses do that too. When you're giving a bath, if you're helping them to the bathroom. I do my full assessment and then I chart the assessment in the room and I just talk to them, ask them questions, get to know them, and sometimes that leads into an educational opportunity. Any questions?
Very informative, I'll say.
Okay.
When it comes to like the readmission and the hospital not being reimbursed for that, how much of that falls upon the client? Like if they're not taking their meds, and, you know, if they're not going.
Or the non-compliant patient. Is that what you asked?
Yeah, like if they're not going to follow-up appointments and stuff like that.
If it's within 30 days, it's the hospital. That's Medicare though. I honestly don't know about private insurance, but most of these patients are over 65, so it falls on Medicare.
So if they're readmitted in less than 30 days, hospital eats that bill.
And don't get the readmission.
Because, I'm sorry, sir.
They don't get the readmission. That's something, a guideline that CMS, the Center for Medicaid, Medicare sets up.
Yeah, but in the private insurances, I don't know about.
And it's because CMS sees it as the initial problem wasn't fixed when they were here before. Is
And
it-
sometimes, I mean, sometimes that is true.
Okay.
And then a lot of times it's the progression of the disease, which
Well,
is why
that
I
was my
think
next
hospice
question.
is such a great.
But what if it's an admission, not related to?
No, it has to do with what your discharge
Okay,
admission
so it
or
has to be
discharge
related to
diagnosis is. So,
discharge.
right, like if you get discharged with a heart failure diagnosis and you're readmitted and then discharged with a heart failure diagnosis within 30 days, then we don't get reimbursed.
Or
But say
something
you get in a
related
car
to
accident.
it. Like if you're discharged with, the heart condition, but you come back with, I don't know, COPD or something.
If your discharge diagnosis the second time is different than
Okay.
heart failure, then you do get reimbursed. It has to be, I know it's
Something
confusing,
related to
and I
the
just
heart
learned about that, we just had a whole conference about this, because we talk about it all the time.
Yeah.
Because it's one of the most, if not the most common readmissions, yeah.
years ago, it used to be pneumonia. That used to be real.
We still,
What
that's
the
what we
hell?
talk about all the time. The core
Yeah.
measures, pneumonia, COPD,
COPD.
CHF.
Yes.
But I guess that's what I'm getting at, if you're looking at heart failure, but if they
Which-
go home and they end up with pneumonia due to being in the hospital and being weak, and so will that be, or there's something totally separate?
If they get, well, so that one would be hard to prove though if you went home, like unless you came back maybe a day later with pneumonia. But a lot of times they do a chest x-ray before they leave.
That's true.
They have to have so many, like that's part of the clinical pathways and why it's such a good idea, because like within the first 48 hours you have to have an echo done. And if you haven't had it done in the past 5 or 6 months. And then you have to have a BNP drawn on admission, and then within 24 hours of discharge showing that you're getting better. You have to show that you've had a
Some of them have
negative
a lab to
1500
get drawn
ml
or something.
output.
Mhm.
So there's so many things, and that's why I think a heart failure nurse giving the education and watching all that is so much more effective than just a bedside nurse who may not know all these
Mhm.
little tiny things.
Because you wouldn't even know to look for all that.
Yeah.
Yeah.
Like we just got into a whole thing about how a lot of times the first dose of IV Lasix is given in the ER, but the ER never charts output. So their first 1800 out is in the ER and it never gets.
It never
So
get
we'll
documented.
know.
And then
exactly.
so it was never done. So there's another tip when you take
So
support
how
from
do
the
you-
ER
so
and you
you
know it's heart
ask-
failure, say
okay.
chart your output.
Interesting.
A little
It is.
above what you're, you haven't done
No,
the subject
actually,
yet, but the
it's coming
education
though.
part
What
is
was
really
being
good.
said.
Yeah.
Y'all mind taking my little quick test?
Yes.
Okay.
Should we record that?
No, you don't have to do that.
Okay, I'm gonna pause now, okay?
Yes, ma'am.